imaging wise and clinically also, we were little worried about the plane with the pancreas. We don't know whether it is
Yeah,
microscopic disease is there or.
because already neo-adjuvant therapy was given 4 cycles of FLOT, and PET scan is a localized disease, and we had no other option. But because and it's not a, it is not, it did had bulky disease, but still it was partially responsive tumor, so we had to go with surgery rather than any alternative treatment.
And finally, was it an R0 or an R1?
R0 because microscopic R0, but margins anyway we got negative only. Lymph nodes status, actually this was operated last week only. We had it to, it's a poorly differentiated carcinoma. So response was there, but it was partial response. So what I wanted to teach from this is really, because head of the pancreas, we have to shave, especially some tumors which are attended to head of pancreas, we have to shave. From this video, it's not a routine thing. Especially tumor is growing to D1, the lymph node stations clearance also will differ. You have to clear the station 13 lymph nodes also, because this is not a routine thing. And when it's going, instead of firing with a very marginal, we have to dissect the part of D1, so that we'll get an adequate length and proper closure is there. Because once the duodenal stump leaks, however good surgery, even if you get R0 resection, the patient is going to have a very terrible post-operative period. So these 2-3 points I want to highlight in the difficult surgery. But as a routine surgery, this is not a part of routine surgery, this is part of extended surgery only.
Any pancreatic leak or any more of collection post-op, any issues for this patient?
No, nothing. Patient is absolutely fine, because once you breach the pancreas, because we have shaved off, drain fluid amylase was rich, but it's well drained. It's a content thing. It's lower because we did in the duct only we had to shave. The plan was to shave the pancreas, so it was drain fluid amylase was rich. The drain was there, so patient had a controlled fistula. It will slowly heal down, so it's not a problem. The problem is with the duodenal stump blowout, because if the pancreatic fluid is there, or vessels, because the vessels also may blow out if there are enzyme fluid is there. You have to be adequately clear and seal off all those vessels, because aneurysms may form. And especially when we are separating the D1, the small vessels, we use a 4x loops, because each vessel has to be individually clipped and ligated properly, because if you tear it and then cause it, and small pancreatic duodenal aneurysms can form. That's it.
Just for the student's sake, sir, to make out on table whether it's a R0 or R1, do you want to do any frozen or something in that area?
So
or are we going with giving the benefit of doubt to the patient?
So 2 areas. One is distal resection margin has to be negative. In this we achieve the distal resection margin. The circumferential resection margin, we have shaved off the pancreas.
Yeah, I'm talking about that area.
That pancreatic area we have separately sent, because it was resected margin was sent. So that we have to assess. So otherwise we have to do Whipple's is not possible in this case, because we didn't want to do such a morbid procedure. More than that, we can pancreatic head, once we shaved off, that is visual only, that a pancreatic head area, that will come on the final HP only. That is the only thing. But other margins are clear.
Yeah, that was a very meticulous dissection that you have shown us. And as far as the R0, R1 should be left to the benefit of the patient, although the overall survival of 5 years drops to 10% from 40, I think the benefit of doubt should be given to the patient. Any questions from the audience?
Sir, regarding vasectomy, do you do for every case, or you are selective in?
So what happened is, before 2018 we used to do for every case, and then after the literature we didn't change, because it has got some 2 important things. When you're doing vasectomy, it is leading you to the anterior capsule of pancreas. From there you can ligate all the gastroepiploic vein and gastroduodenal gastroepiploic artery to the base and clear all the adipose tissue. That can never be cleared if you don't do a proper vasectomy. Then again you have to dissect there and then lift it. Once you are from the transverse mesocolon, easy case it's difficult. But the second case is where the vasectomy has purported benefits. That is also, even in posterior gastric tumors, oncologically it has got no benefit. But resection wise, what I found, my personal experience is, clearing the lymph nodes and lymph node clearance, staying on the anterior capsule without injuring the pancreas, we can safely do in certain cases. If it can be done, it should be done. That's why we approached from right side and left side and did the pancreatic part late, when it's difficult. When it's easy, it's always easy to, but you have to maintain the correct planes. Once you go into the parenchyma and injure also, then that amylase-rich fluid leakage, collections, infected collections, all these will be a problem in vasectomy. That's why, because of that collection complications only, vasectomy is not recommended as of now to date. Even for posterior gastric tumors, not recommended.
And sir, this peritoneal wash cycle, do you go for every case at outset?
Peritoneal, as part of study, we used to do for every case previously, but now we are not doing, because even it is microscopic positive. But we do wash and then give positive. If it's positive, we should still proceed only, because already neo-adjuvant is given. but it's, as routine we are not doing. But T4 and advanced disease we should do as a routine policy.
Yeah, to the extension of question what Dr. Nagendra asked, see, the reason we were discussing morning also, early gastric cancer, the concept now is minimal invasive in the sense that more conservative surgery with preservation of the function. But when we come to locally advanced gastric cancers, it is more of radicality with the aim of achieving R0 resection. Now in this your patient, you gave the neo-adjuvant therapy and you assumed that it was resectable. And actually when you do the pancreatic margin, you said you are not prepared to do a Whipple's, but if your frozen is positive at that time, so how do we proceed at that time? Because we are not prepared for Whipple's, but we have taken a chance to do a radical resection. We have completed the rest of the radicality and we have left that in the end.
No, this pancreatic shaving is the early part of, because that's why once we open the lesser sac, the operability will be decided there only. So we have exposed the superior mesenteric vein. From the right side I came, left side I came. Then what is the area of adhesion? Can I be able to do a reasonable job? Then only we should proceed. Otherwise we can abandon there and then itself, because we have not done lymphadenectomy anything. Only thing I wanted to show is, if it's adherent, don't go through one approach. If possible, come from around also and have a look. Because distal pancreatectomy, if it's body growth, you can easily do a distal pancreatectomy, splenectomy. Head tumors, some Whipples we did do, but they don't do well because the biology is so poor and the patient, we have done 1 or 2 Whipples in some selective cases after neo-adjuvant therapy, but then we know the prognosis is poor.
So one last question, any role of clipping here? Since it's a T4B lesion, do you want to clip?
Yeah, for radiotherapy, yeah.
Yes. So probably you can clip it and...
because definitely that's the there is definite role for radiotherapy post-op in these cases. Because the guidelines don't adhere to this locally advanced and infiltrating tumors. All the guidelines we should remember that is for other operable cancers. When we are extending the resection, even if the mesocolon is involved, 14V, 14A nodes have to be removed. So because already mesocolon is infiltrated means the nodal spread is also going on. So all those nodes we have to clear. That's why we exposed the SMV and cleared the nodes. Should not be taken as very standard, but it's in certain selected cases we should do. That's my option. But the first surgery is what we should do in a routine cases. Thank you.